Good afternoon, and thanks for joining us for Healthline 3. I'm Jamie Ostroff, and today we are here with a doctor and physician's assistant. Yes, from Regional Urology. We are here to talk about advanced prostate cancer for the next half hour, and we want to encourage you to ask what is on your mind. So if you are online, just go ahead and click on the Healthline 3 box halfway down the right side of your screen. You can type in your question and submit it to us that way, or just pick up the phone and give us a call. We've got the number right there on your screen, 318-219-4569. We're going to be here taking your questions until 12:30. First of all, welcome, and thank you for joining us.
Thank you for having us.
All right, so we gave a little preview during our midday newscast, but just to recap for those who might just be tuning in, advanced prostate cancer, how does that differ from perhaps other cases? You said it was about 50% of cases are advanced.
Well, let me back up a little bit. So if you take all prostate cancer, about 50% are so indolent or slow growing that they never need to be treated. We just keep an eye on them. The other 50% are not advanced yet. So they are clinically relevant cancers that need to be treated. And then advanced prostate cancer is about 10% of all cases. And that's when it gets beyond a cure stage into a try to control it stage. And then it gets a little more complicated because there's early advanced and late advanced. Early advanced prostate cancer is treated simply by turning the man's testosterone production off, because the male hormone testosterone acts like fuel for prostate cancer. So back in 1944, Dr. Huggins identified that if you castrate a fella, his prostate cancer basically goes into remission. Won a Nobel Prize for that.
Wow.
And so move forward into the 80s, we developed medications that turned off the testicle so you didn't have to have surgery for that, accomplished the same thing. That was 1944. We didn't have anything to offer those men until 2006 other than that. And then finally in 2006 we had a chemotherapy. In 2010 we came up with immunotherapy, and we've had 3 oral drugs since that time. So we really have an onslaught of new medications that are coming out.
So you've talked about, you mentioned cure, and then you've mentioned treatment. What is the difference between cure and treatment?
So like Dr. Henderson was saying, when you catch it early, it's typically either we just watch it, it's indolent, it's not going to progress, we don't need to do any treatment. For those patients who have a little more aggressive cancers that do need treatment, then that is curable typically. And we just follow them. We follow their PSA, make sure they're doing okay clinically. You know, usually we offer surgery or radiation to treat in terms of curing. But like Dr. Henderson said, 10% of patients will progress and move into the uncurable stage where we then treat. So there's a difference between treat and cure. So we just have to make sure that we educate the patient to know the difference between the two.
So a treatment is more of a management.
Right,
of
we're
the
slowing
symptoms.
the progression of the disease. So we're not curing it, but we're slowing the progression, which means that they can manage it and continue with the quality of life that they've been accustomed to living with.
Can someone live the full duration of their life without it being cut short by advanced prostate cancer?
It depends, you know, again, like how early you catch it. If they're in the early advanced stage, I would say yes, you know, the treatment options that we have available to us now allow the patient to continue with the quality of life. Now it will progress, so we just have to have conversations and follow them a little closer so that when it does progress, that we can then offer the next layer of treatment.
And Dr. Henderson, you mentioned chemo wasn't available for advanced prostate cancer until 2006?
That's right.
How is chemo for prostate cancer different than chemo for different forms of cancer?
Well, it's the same drugs basically, and every chemotherapy has to be tested against each cancer type to see if it works, if it actually kills the cancer. And so all of the previous chemotherapies had no effect. If you gave it to a prostate cancer patient, the cancer just basically laughed at it and kept on growing. And so in 2006, when they, I don't know if you remember back then, the Pacific yew tree, in the bark of that tree, they found what's called a taxane. Taxol was the first one. Big breakthrough for breast cancer, which, like prostate cancer, is another hormonally sensitive cancer. And so they said, let's try it against prostate cancer, and that became the first effective treatment.
And how does prostate cancer differ from other forms of cancer?
Well, each cancer retain some of the characteristics of the organ it started in. All right, so prostate cancer starts in the prostate, and when it spreads, it's very predictable. It goes first to the pelvic lymph nodes and then into bones, and usually the bones of the spine. And that's just, again, because it tends to favor areas where it can find some hormones, and there happens to be hormones in our marrow. So it is not, even in its fastest form, it's not a fast cancer like people think of with pancreatic cancer or stomach cancer, something like that. So, the silver lining to prostate cancer is that it's 99% curable if caught early, and then even if not caught early, we can treat it and contain it, like Sarah said, maintain quality of life for a decade or more.
And you were mentioning earlier before this program, a lot of cases are not caught until they reach those advanced stages. Why is that?
Well, there's a number of reasons. Men don't come in to see the urologist. Some doctors don't check for prostate cancer, and it doesn't have symptoms. There are no symptoms until it's in its latest stages. So it really requires an annual checkup to catch prostate cancer early. But even checking early, there will be a small number of men, and it is small, it's less than 1%, who are going to have advanced prostate cancer, even with annual checkups that just forms within that 1-year interval.
But it really does increase chances greatly of catching it in that curable stage.
Absolutely. Yeah, again, it's 99% curable. So for all cancers, that's a really remarkable number.
Right. And there are some symptoms involved with prostate cancer. They don't always show up early, as you just mentioned, but tell me about some of those symptoms that might eventually show up.
Yeah, later on as the cancer grows, one thing it will do is affect urination, because the prostate is between the bladder and the exit of the body for the urine. And so as that cancer grows, it obstructs that flow. So men have a harder time urinating, may see some blood in their urine. Then as it spreads, like I said, to the bones, lower back pain is a very common symptom that men will have.
And what do you recommend at that point if they are experiencing things like that?
I would say if you're having anything outside of your normal baseline, then you should be proactive and see your physician. You may not immediately make an appointment with your urologist. If you've been diagnosed with prostate cancer, I would recommend following with your urologist yearly, just to make sure the PSA is low and clinically you're manageable. But if you're uncomfortable making a specialist appointment, at least see your primary so they can assess, is it low back pain, is this cancer related, and then funnel you where you need to go.
Walk me through the diagnostic process. Someone comes in either just for regular checkup and screening, or because they're having symptoms and want to know if this might be prostate cancer.
Sure, so it's the same diagnostic process if you're talking early or advanced, and that's a rectal examination. The prostate sits right in front of the rectum. Most prostate cancers form on the back side of the prostate, so it's easy to feel the cancer. It's a real hard nodule or knot that grows there. And a PSA, a blood test that measures PSA, is a protein secreted by prostate tissue, and it's secreted in higher numbers by cancerous tissue. So those are the first two clues that there may be cancer there. And then we do a biopsy, which is putting a needle into the prostate to take a little sliver of tissue. A pathologist looks at that under the microscope and tells us if there's cancer there. And so that's how it's initially diagnosed, localized or advanced.
So someone finds out that they do have prostate cancer. What is next?
So we'll have a conversation about options. We'll do CAT scan and a bone scan, what we call a metastatic survey, to look and see if it spread anywhere. If it has spread, prostate cancer is now a cancer that we can still try to cure even when it spread some. But hopefully we've caught it before it spread, and our options are watching it. If certain parameters are met and it qualifies as one of those real slow growing cancers, or taking it out by surgery, or killing it by radiation.
And how do you approach that in terms of personalized treatment? I know treating cancer can vary greatly patient to patient.
Yeah, so we do have genetic tests now where we can test both blood and the tissue to see the characteristics of your particular cancer, what it would respond to in the way of medications or surgery. So it's sort of personalized in that regard. And then with advanced prostate cancer, going past the surgery and radiation, we talked about the chemotherapy. Talked a little bit in the news show about the vaccine. That again is a huge breakthrough where we'll take a man's blood and take the white blood cells out And well, Sarah, you tell them about it.
So immunotherapy, we've been offering at Regional since 2010 is when it was FDA approved. And I think it's a great option for patients because you're actually using their own body's defense mechanism to treat their cancer. So we're supercharging a specific type of immune cell, taking it out of the body. It goes through some in vitro mechanism of action where the cells are supercharged, then we put it back in the body. So we've taken some immature defense cells and then allowed them to mature outside of the body, put them back in the body where they can then rapidly recognize the cancer and go ahead and kill the cancer cells. So it's very well tolerated in terms of side effect profile. It's not like chemo. It's not a poison that we're putting into their body. We're putting something that's actually theirs. So they don't have the hair loss, all the GI problems that come with chemo. And it's 3 cycles of treatment and you're done. So we can basically give a patient immunotherapy within 6 weeks and it can extend their life. And I mean, I've seen it work clinically. It's really cool.
Wow. And yeah, my next question was going to be about side effects. Are they minimal or are there none?
No, I mean, nothing comes without some risk. They have to go through a collection process where they've got a peripheral IV in either arm, or, we do it through a port. And then, so that's, just logistically, they're having to go and have their blood drawn and then come back for the infusion. And it's typically, if they do have side effects during the process, during the infusion process, they can have a little bit of allergic response. They can get a low-grade fever, chills, which we manage in the clinic. And then they can sort of feel like they have a mild case of the flu 24 to 48 hours afterwards. But that's basically it. We pre-medicate them to offset any issues, and I would say 90% of the time, patients, other than just having to come and see us, don't have any side effects at all.
Which, for those who know how chemotherapy and other treatments can affect a person going through it, that sounds remarkable.
It is.
And you mentioned that the immunotherapy is being tested to treat other forms of cancer?
It is, for liver cancer, kidney cancer, and bladder cancer. That I know of. I don't know, have you heard any others?
Breast and colon, but I don't know as far as the progress.
And we've been talking about the remarkable levels of innovation that have occurred in the treatment of prostate cancer over, really the past decade and change. So not that long. Tell me about some of the other things that are out there in terms of understanding and treating the disease.
So one of the treatments that's newer, I think it's been around for about 4 years, is radium. It's a radioactive material that concentrates specifically, it targets cancer growing in the bones. So it's not unusual for an advanced prostate cancer patient to have 3 to 5 or more areas of cancer spread around the body and the bones, hips, legs, ribs, backbone. And we give an infusion by the IV of this radium, and it goes like a smart bomb and finds the cancer in the bones and delivers radiation treatment by adhering to the bone where the cancer is and radiating it directly by contact. And it's a very high dose, but it's very short-lived. So in other words, it drops its bomb and then it's benign. It's no longer radioactive, kills the cancer where the cancer lives, and extends life, gets rid of pain, and it's really a great breakthrough.
Wow, that is pretty remarkable. You think radium, at least as a person like me who frequently goes down the rabbit holes of Wikipedia, you think of the history of radium, the watches and the radium girls, and to know that it can be managed and kind of targeted into a treatment, that's pretty impressive.
Yeah, it's pretty cool. We've had a number of patients receive that over the past few years. Again, like the Provenge, the immunotherapy, with really amazing responses.
And you're seeing the survival rates, I imagine, go way up, and quality of life as well.
Yeah, prior to these latest advances, when a man gets into that advanced stage, usually had about 2 years of life. Now we're looking at 10 or 12.
Wow, and all right, and we are almost halfway done with Healthline 3, so I still want to give you an opportunity to call in. You've got the number right there on your screen, 318-219-4569, here with Regional Urology, talking about advanced prostate cancer, and we would like to hear your questions. And as we do that, I actually, I told my dad if I had time, I would ask one from him. He's very interested in medical innovation, and he wanted to know if you knew anything about something called CyberKnife.
That's a great question. Yes, it's It's a sort of like a gamma knife that's used in neurosurgery. It's a very precise beam of radiation that, so without a knife, the radiation goes into your body and kills the prostate cancer without causing damage to the surrounding tissues. It's, and as opposed to traditional radiation, which lasts about 9 weeks of going in 5 days a week, CyberKnife usually lasts about 3 weeks.
Wow. And is that something that you have at Regional Urology?
We don't currently have. There is a place down south that has it, in the Lafayette area, I think. But what we do have is actually we're getting what's called SBRT, or stereotactic radiation, which is going to cut treatments down to 1 week.
Wow, and tell me how that works.
Well, it's similar to CyberKnife, just a very high dose instead of low dose spread out over 9 weeks. You have to have very precise equipment when you're delivering a high dose. Our equipment for radiation has a margin of error of 1/10 of a millimeter. So you can imagine, that's a micron basically. That's, so
wow.
we're precise in where we deliver that beam, and so you can give high doses without worrying about surrounding tissues being damaged. And again, so just high doses, 5 days of treatment, and that's something we'll be able to offer within 2019.
Okay, good to know. Some new developments around the curve. Talk about how important it is in the field of medicine to stay on top of continuing education and new developments in treatment care, and making sure you have it and you can give it to your patients, investing in that.
Well, continuing ed is, first of all, is mandatory, right? To keep your license, you have to do 20 hours a year. And then the organizations like the American Urologic Association we belong to actually is more stringent, or the board, to maintain board certification, requires 60 hours of urology continuing ed a year. So, it's mandatory. But it's also necessary just to keep up. Like you mentioned, the past decade has just been, a real, avalanche of new therapies. To be able to use those and maximize treatment for your patients, you have to stay abreast of everything. And then not only do we have new therapies, but then you have to learn how they interact with one another, what side effects or what synergies are there.
Synergies?
So when when something has an added benefit, so for example, if you take advanced prostate cancer and we use the radium and an oral medication, instead of having a 1 + 1 = 2, you get a 1 + 1 = 5.
Oh.
So you get more of a benefit as far as quality of life and life expectancy.
All right, that's very interesting. And we do have a caller on the line, I understand. What's your question?
Yes, my question is to the doctor that I had prostate cancer, and then it spread it to my rib, and a real small little dot, not big as a penny, about half the size of a penny. And they're giving me a medicine, give me a shot in the stomach every 6 months, and give me a drug, XTANDI. I'd like to know, how far along is this cancer, and how does it coincide with shock treatment?
Okay, so Sarah runs our Advanced Prostate Cancer
I'm
Clinic.
not hearing anything. I'm sorry. I was like, is this supposed to work?
So yeah, this gentleman is receiving a shot in his stomach every 6 months, which is Lupron, right?
Right.
And has a rib metastasis and takes Xtandi. And you have a lot of experience with Xtandi.
Yes.
So he's interested to know how advanced his cancer is, and maybe just lay the landscape of where he's at.
So if you're on Xtandi, currently it has 2 indications. You can use Xtandi in the M0 space, which is not what he has. He has a rib metastasis.
Right.
So your cancer is advanced, but it sounds like it's well managed. You're getting, the guideline recommended treatment. You would stay on your 6-month hormone shot because we do know that a subset of the cancer cells will continue to respond. However, you've got this rogue subset that's gone to the rib, and now you're treating that with Xtandi. And as long as your PSA remains low, you're not progressing clinically or having any new spots show up on imaging, I would say your treatment care is on point.
Yeah, and the other thing is if it's only in one spot there's an option to talk about delivering radiation to that one spot.
To that one spot, especially if there's pain involved with that rib, I would definitely ask your urologist to see what they recommend. But yes, we do have palliative radiation to spots that have gone to the bone that help treat the pain.
Does that help?
I think I hear him on
Yes, that helps a whole lot. And I appreciate it, and I thank you.
You're sure welcome.
All right, thank you so much for calling in, and I hope you're well. Again, still another 10 minutes to give us a call and ask your questions about prostate cancer. The number 318-219-4569. Another thing I wanted to talk about today, you know, we've talked about the treatment, we've talked about the technology, but then there's also the just human aspect of treating cancer. It's a difficult thing to hear that you have cancer. It's a lot for not just an individual, but for a family to go through. What does Regional Urology do to support patients and their families going through something like this?
That's a great question. The first thing that comes to mind is we have such a high volume in our prostate cancer clinics, Sarah and I and the other physicians, that you never get used to talking about cancer with people, but you get to the point where you've seen basically everything, and you can relate to people what they have to anticipate, and sort of give them expectations. And it's a process that we go through together. When you have advanced prostate cancer, we're going to see you monthly, and again, the team we put together in our advanced prostate cancer includes not just us, but a medical oncologist, a guy that gives chemotherapy, a radiation oncologist, and so you have a huge team of input on your condition. We do have a support group, which meets actually starting it has been every other month. Starting in January, it will be monthly. And so this is a Tuesday nights where men and their wives and families get together. We try to have a speaker each time, educate people about, you know, the disease in general, but the main thing's not us educating. It's the people who've actually lived through it, being there, sharing with each other and supporting each other, and saying, look, I'm having this. Oh yeah, I went through that, and here's what helped, and here's what didn't. We also have a patient advocate, so a lot of these medications that we're talking about are very expensive. So Samantha Purcell's our patient advocate, and she is tasked with finding funding for these there's a lot of foundations and patient assistance that we can tap into, and so that, again, that's part of the team, and I'm personally really proud to be part of such an advanced thing. Nowhere else in the state has a prostate cancer team like this, and as a matter of fact, outside of academic institutions like MD Anderson, nowhere in the country has a one-site treat all stages of prostate cancer like we do.
So you really do everything from the diagnosis to treatment and cure, surgeries as well?
That's right.
And you know, I think we touched briefly on the surgeries, but it has gotten a lot less invasive over the years in terms of treating prostate cancer.
It has. You know, with the advent of laparoscopy, where we take little scopes and do the surgery without making a big incision. And then there's this Da Vinci robot you may have heard of.
Yes, I have.
And that's just using laparoscopes with, and people think it's a robot like you'd see on a assembly line with cars, which it's not at all.
It's a little intimidating sounding when you think of it that way too.
It is, and what it is a tool that your surgeon drives, actively makes tiny little hands go into your body where the prostate is located deep in the pelvis. It's hard to get to traditionally, and so think of tiny little hands going down into your pelvis and then having a magnifying scope just an inch or two from the target tissue, instead of a surgeon who's operating just with his eyes, you know, at the end of his arms. So it really allows precision, and what that means is the surgery is turned from a 3-hour surgery with 90% of the patients needing a blood transfusion, staying in the hospital for a week to 3 weeks, wearing a catheter for 3 weeks. It's taken that to an outpatient procedure. Go home same day or stay one night, wear a catheter for a week or less, virtually 0% risk of needing a transfusion. So it's totally changed the landscape there. The other thing that precise ability allows us to do is preserve erections, whereas open surgery was much less fit to do that, but also to preserve bladder function. So with the old traditional surgery, about a half to 2/3 of men had to wear diapers the rest of their life. And now with this, it's only about 1 out of 100.
So a lot of men I know are very nervous to go get a screening, and you know, to know that there's such easier levels of treatment out there than they used to be, a lot less intimidating, I'm sure makes it a lot less scary to go and get checked.
Right.
So definitely go get checked.
Definitely.
Yes, and also you make an interesting point that the treatments are less likely to interfere with sexual health.
Exactly.
Yeah. Talk a little bit more about how the immunotherapy or chemotherapy might impact sexual health, if at all.
I mean, there's no side effects from the immunotherapy in terms of, you know, sexual health being an issue. Chemotherapy, I'm not as clinically experienced with, but you do have a lot of just fatigue and, you know, your baseline changes, so.
Well, the important part is those advanced prostate cancer patients are also receiving a shot like the gentleman talked about. And that shot is the chemical that performs the chemical castration. Right, that's the shot that turns off the testosterone.
Okay.
Right, and replaced having a surgical castration. So a man has no testosterone who's receiving immunotherapy or chemotherapy. That lack of testosterone pretty much takes any desire away to have sex, but it also takes away a lot of the ability. So in the advanced prostate cancer group, that's not a common issue anyway for chemo to impact. But I do want to, you brought up a great point. This immunotherapy, this vaccine that we use called Provenge, is also being studied now in men who are on active surveillance. So get this, because this is a huge potential breakthrough. Right now it's only approved for men with advanced prostate cancer to educate their immune system to attack the cancer. So what we're doing is, remember those 50% of men who have cancers that don't need to be treated? We are giving Provenge to them through a clinical trial. So you've got a tiny amount of early prostate cancer, looks like it's slow growing, and the theory is by giving them this treatment, it will eliminate the cancer from their body totally.
Wow.
And if this trial is successful, the next option would be to give it to men prior to prostate cancer, so that like a true vaccine, say against smallpox, you know, we then have the ability to have the educated immune system that the minute a cancer cell forms in the man, his immune system knocks it out, so then he never gets prostate cancer.
Wow, and you know, and I remember, you know, I guess from the female equivalent of things, how 10, 12 years ago they came out with Gardasil, the HPV vaccine to prevent cervical cancer. And like you're saying, you think we can see these types of immunotherapies and vaccines coming for other cancers too?
Absolutely.
And naturally that can be huge. So I'm watching the clock right now. We've got 2 minutes left. I got to apologize to our final caller. If you've got a really quick question. To our final caller, if you've got a really quick question. I'm not sure if we have that caller on the line. So here's what I want to do in our last couple of minutes. Do we? You know, if I hope the caller can speak up if we have you on the line. I hope the caller can speak up if we have you on the line. All right, we do apologize for that. So let's take these last few moments. I know there are so many reasons that you know, men often don't want to go to the doctor regardless of what's ailing them, especially if nothing is bothering them. So I want to take these last few moments to make one final plea and one final argument to urge everyone out there just to get checked.
Yeah, absolutely. It's totally curable. It just requires once a year a blood test and a physical exam. And you know, importantly, it occurs in 1 out of 6 men in the United States. 1 out of 6.
Wow.
The most common cancer in the United States, other than skin cancers. And it's the second leading cause of cancer death. Approximately 30,000 men die every year of prostate cancer in the U.S.
Wow.
And again, that's almost universally preventable.
And we can cut that number way down.
We absolutely can. PSA, the blood test I've talked about, has already cut it down by about 60%. So,
wow.
And that came out around 1990. So we've had advances. It's been an exciting time to be part of this treatment.
All right, wonderful. Well, that is all the time we have, folks. Thank you for watching. Stay well. All right, thank you guys.